All right, welcome everyone to our webinar tonight. Really so excited to bring this content and these presenters to you tonight. The title of our webinar is A Revolutionary Approach to LSVT BIG Treatment. My name is Laura Gousset. I'm a physical therapist and one of the LSVT BIG training and certification faculty, and I will serve as your moderator tonight for our session. With us tonight are featured therapists from the Parkinson's Disease and Movement Disorders Program at the Minneapolis VA healthcare system. So with us are Derek Kent, an occupational therapist who is LSVT BIG certified, and Hillari Olson, also a physical therapist who is LSVT BIG certified. And last but not least, Emily Doby, an LSVT BIG certified physical therapist. So these are our featured presenters tonight. Just so grateful to the three of you for sharing your time with us and sharing your knowledge. This is a very popular topic. A lot of people want to know about this hybrid approach that you've developed regarding, LSVT BIG delivery. So I'm not going to read through their biographies, but Derek and Emily and Hillary will introduce themselves later in our webinar. These are here for your reference if you want to keep the slide handouts, which I'll pop into the chat box in just a minute. A few disclosures that we do want to give. There are no financial relationships that exist between parties and no non-financial relationships to disclose. We do want you to know that this presentation is educational in nature. It's not intended as an endorsement of LSVT BIG by the VA healthcare system. It will highlight their program, their LSVT BIG Outpatient Program that they offer at the Minneapolis VA, but it's not the only treatment option that they offer for patients with Parkinson's or other neurological disorders at that center. A few logistics. I'm sure that most of you are quite familiar with Zoom, but just as a reminder, please keep your microphones muted throughout the presentation so that there's no background noise from your different environments. We really want this to be an interactive webinar. The presentation of the slide content is going to be fairly brief, where Emily and Kent will give you an overview of their program and the development. But we hope that this sparks a lot of questions about how this might work or logistics, things like that. So please, at any time, put your questions into the chat box of your Zoom control panel. After they're done sharing their slides, we'll stop screen sharing and we'll open it up for a lot of questions and answers. And our goal is to really answer as many questions as we can. That said, if you think of questions later after the webinar is over, or you're listening to this later as an on-demand recording, you can always email webinars@lsvtglobal.com and share your questions, or you can send them to info@lsvtglobal.com and we'll be sure to get answers for you. The handouts were emailed to you today if you registered for this webinar. However, in a moment, I'm going to put them into the chat box. At the end of the webinar, there'll be a short survey for you to complete. Please let us know what you think about this topic, if there were any technology issues, and if you have any suggestions for future webinars as well. A few tips on CE activity. So just know that you can use this to self-report CE if your state accepts self-reported CE credit. This is not pre-approved or pre-registered for CE activity. If you do attend the live webinar, you will receive a certificate of completion if you attended the full hour. We will email those to you. It might take a couple of weeks, just depending on the volume of certificates that we have to create and send out. If you are listening to the on-demand webinar and want CE credit, there is a survey that you'll be able to complete and request a certificate as well. If you're not sure about self-reported CE credit, best thing to do is to contact your state board, read your Practice Act, and see on the CE approval requirements. So these are the objectives for our webinar today. I will just read through them briefly. You can read through them at the same time. we're going to be comparing the traditional model of LSVT BIG treatment delivery with the LSVT BIG Hybrid program that they've developed for people with Parkinson's disease. Identify the specific strategies used in their program to ensure safety during telehealth sessions while still achieving positive outcomes. Reflect on the role of the interdisciplinary team in that outpatient program, including PTs and OTs. We're going to talk about the benefits and limitations of this model, how to identify patients who might be good candidates. And then at the end, we'll just remind you of a few resources that are available to you if you're interested in this as well. So before we start our presentation, we just want to pop up a couple of poll questions now that a lot of people have joined, and we really want to get to know who is joining us tonight. So the first question is, are you PT or OT professional or student? Everyone's welcome to this webinar, but we'd love to know who exactly is here. So I'll just give you a few seconds to answer that. All right. Looks like almost everyone has answered. All right, I'm going to go ahead and end that poll. And good, looks like we've reached the right people. We have about 96% who are PTs or OTs and about 4% that are others that are interested. So welcome everyone. Glad to have you. All right, second poll is this. Let's see, here we go. Okay, if you're a therapist, do you work for the VA or for the private sector? So go ahead and take a few seconds, answer that one as well. And please note that this webinar is going to be relevant for therapists in any system. All right, looks like almost everyone has answered. And we've got 70% from the VA healthcare system. That's awesome. And about 30% from the private sector. Okay, great. Okay, last thing before I turn it over to Emily, just to get your fingers used to the chat box, if you could type in the chat where you're from, like what state you're from, or if you're from a different country, what country you're from. And while we're doing that, Emily is going to pull up her slides. All right, so Emily, we're kind of from all over North Carolina, Ohio, California, Pennsylvania, New York. Wow, Florida, another Ohio. This is really fun to see. Maine, good. Some from Kansas, where I'm headed on Wednesday for AOTA. New York, Nebraska. Goodness gracious, I think we're almost hitting all 50 states. That's awesome. All right, thanks for joining everyone. All right, Emily and Kent, I'm going to spotlight you and turn it over whenever you guys are ready.
I'll let Derek start off with the history.
Right. Yes. Thank you, Laura. Just as Laura had said, my name is Derek Kent, 2 first names. So easy to confuse. But just to let you all know, just as she said, we're going to kind of focus or we're going to primarily focus on the hybrid program itself, rather than, all the offerings that our program has to provide or what we do offer. There are plenty of things. We're just going to kind of focus on that hybrid aspect itself and how it is that we are delivering the LSVT model in a virtual manner. But just to give you a little history of our program and the history at our VA, back in 2017, I and Hillary and I were working on a transitional rehab program. It's a residential rehabilitation unit that was developed for people coming back from the Iraq and Afghanistan wars, coming back needing a little bit of extra attention originally in helping them kind of transition back into society and back into their lives. Given the time frame there in 2007 or 2017, we were realizing that we needed to fill some more beds, and we saw that the PD population was one that we were heavily underserving, and we came up with a program to offer some of the LSVT underpinnings in an inpatient intensive program for our veterans with Parkinson's disease. We started that back in 2017, which was the same year I think we all got LSVT certified. Then, during the COVID years, we started to transition more into realizing we needed to offer this as an outpatient and continue to follow people with Parkinson's disease along the way. So in 2020, we received Vision 23 strategic initiative funding for 2 years, and I believe that was it was taken up again. It might even be more of a permanent funding that we have now for us to continue with our PD and PD services, to continue to expand our program and the services that we offer. And then back in 2021 was when we had our first pilot of the outpatient LSVT BIG Hybrid Program. We run this, and Emily will get into it a little bit more about the kind of structure of it and how often we're seeing our patients, but we do follow the protocol itself pretty closely. You can go ahead and move along there, Emily. So now, as I had mentioned, the development of the hybrid program, this is more, and when I say the hybrid program, this is no longer our inpatient program, which we still continue to do. This is more of the outpatient delivery model that we're providing the LSVT BIG training or protocol through. The reason that we came up with this, and the reason that we started to do this, is that during COVID, we were actually shutting that unit down based on the residential nature of the program in general. So we weren't able to get people out into the community as they were intended to. So we stopped admitting people in that program and realized that we needed to continue to serve this population and serve by providing the LSVT model. So we began and found ways to provide this protocol through a hybrid model, hybrid meaning both inpatient or in person and online. As it says right there, lacking mechanisms to provide LSVT BIG protocol on an outpatient basis within the VA due to our limited staffing and resources. The outpatient program itself consists of 1 OT and 3-ish PTs, all of us having clinic structures that do involve virtual clinic time and face-to-face, but given kind of how our clinics are structured or how they're put together, it wasn't going to be feasible for us to do face-to-face only. During this time, also the expansion of the VA telehealth platform, we were really pushing for increasing our virtual telehealth offerings and the opportunities to deliver care in a virtual manner. So that was another big push by the VA. So we thought that maybe we could make this happen. And then the need to accommodate some of those veterans who cannot commit to our inpatient program, whether it be for the 5-week requirement of being, in the hospital, or also, in addition to that, some of the distances they're driving, they're not willing to come in 4 times per week to the VA. We're able to still offer this to those individuals that have some of those unique characteristics. By doing this, we were able to alleviate our reliance on the community care referrals that we were otherwise sending out in order for our veterans to receive LSVT BIG. And then, we realized that there was this ability to meet the protocol in this hybrid format, hybrid meaning both in person and virtual, as indicated by the LSVT BIG criteria that you all should be familiar, or most of you should be familiar with.
And now I'll jump into a little bit of how we kind of run our program, this hybrid platform. So as you can see here, it's a total of 6 weeks. So our first week is going to include 3 face-to-face sessions with both PT and OT in order to complete our pre-program evaluations. So either PT or OT will have 2 sessions with the patient, and then the other will have 1. And this allows us to make sure that we're completing the evaluations more fully, including doing some videotaping. Weeks 2 through 5 are the intensive protocol. And the way that we do that is 1 face-to-face session per week with either PT or OT and 3 virtual sessions per week. So as Derek was mentioning before, a majority of the program is going to be done virtually from home. And then as far as the face-to-face session, like it says, it's either PT or OT. So for example, if we have 4 people in a cohort, 2 would see myself with PT and 2 would see Derek with OT. Week 6 is the final week. We put in 2 virtual, what we call buffer sessions. So if a patient had to cancel for some reason, or maybe we had some technology difficulties, we're able to utilize these buffer sessions to complete the protocol and get the full 16 sessions. The second half of that week, we also complete 2 face-to-face sessions with PT and OT in order to complete our post-program evaluations and really kind of go through and show the patient how much they improved while they were with us in this program. Now, when we look at this program, obviously there are some things we want to take into consideration as far as who is an appropriate candidate. So first off, we want to make sure that they're telehealth capable. So they have an adequate internet connection and that they have something like an iPad, tablet, laptop to utilize. A desktop can be used, but it's not as flexible as a laptop or tablet. And we'll get into that a little bit more later. We also want to make sure that the patient has the cognitive ability to follow that more complex schedule. So making sure that they're able to come in for the proper face-to-face session and knowing which days are virtual versus face-to-face. And then also just being able to sign in to a virtual session. So kind of understanding the virtual platform, things like troubleshooting. We want to make sure that we're not spending 30 minutes of every virtual session trying to help them to get connected. We also want to make sure that they respond well to verbal and visual cueing in person, but also over video, because we're not able to be there to provide the shaping and those hands-on facilitations. We want to make sure that we're getting the amplitude and the movements that we're desiring solely through those verbal and visual cues. We also want to make sure our patients are safe. So we want to make sure they're able to perform more dynamic activities without hands-on assistance or close guarding. And so making sure that when we're considering who we want to kind of participate in this program, we're keeping safety at the forefront, making sure that we can adequately challenge them, but do so in a safe way.
So this is just kind of a side-by-side comparison of the traditional model of LSVT and our hybrid model. As most of you probably know, the traditional model it revolves around all face-to-face care, as well as our inpatient model that I had referred to before. Of course, that's a wonderful way of administering the protocol, but we realized there was a void with some of the distances that our patients our veterans are coming from, and wanting to get this great protocol out to them, we had to pivot and ensure that we could reach them, and the best way we were able to do so was through this virtual model that we had developed. One of the benefits, of course, with the traditional model is the hands-on aspect and the live modeling with the tactile shaping and pushing people to their largest amplitude. We do our very best in doing that by providing some of the verbal cues and the modeling from this virtual manner. I will say that oftentimes during our virtual sessions, I'll have people stop mid MDE, maximal daily exercise, and say, go ahead and take a look at how your arms are outstretched, and take a look at how your feet are positioned. Are they too close? Are they far enough apart? All those different things, just to kind of add to some of those things that we may be missing from the tactile aspect or the hands-on cueing and shaping that we were doing from the traditional model. One of the benefits, of course, this is why we also really prefer, we like having our one face-to-face, is that option for the creative space utilization. We have access to a lot of other materials that we might not otherwise be able to achieve through the virtual means. Most hospitals have a number of different items that can be used to train gait and make it a little bit more complex that we kind of miss out on. But we do our very best, and we try to get as creative as we can. And we've even asked for our veterans to find things around the home that we can use to increase the challenges. I know one of the more recent ones, I had a guy using some bird houses that he had just made to try and increase the amplitude of his steps forward and backwards. And as we know, the daily treatment sessions allow for more frequent hands-on feedback, but we do, like I said, do our very best to make this as complex and graded to the right level of function as we can. So when we do see them, we in person, we try to maximize those in-person sessions to come up with some of those creative ideas and really challenge some of those things. We don't often want to the very first time challenge somebody too much in the virtual sense until we've kind of seen them hands-on, where we can kind of guard and block and things like that to ensure safety. But yeah, move on to the next one. Of course, safety is always of the utmost importance in anything that we're doing as clinicians. So this is something that we're constantly evaluating. Emily and I are talking very often about things that we've seen with the patients that we're working on or working with during the cohorts that we're providing throughout the week. But first and foremost, I would say this is true for just about anyone that we've worked with. We do have them start with the adaptive standing exercises just to ensure that they have the hands-on kind of safety net when they are making some of these dynamic movements, and then kind of trial them on a first face-to-face basis. Or we may, if we do feel comfortable enough, have them just trial it. But oftentimes we see, and some people get a little discouraged, that they are still using a chair, but they're not allowing themselves to really emphasize the amplitude, that we're actually benefiting them a little bit more when they are having their hands on the back of a chair, to allow them to really maximize that balance. We try to educate and support them as much as we can, but of course our ultimate goal is to eventually move to unassisted. As I had said in the last slide, we trial more of our dynamic tasks during the face-to-face sessions for the very first time, just until we're sure that this person is going to be safe. But after running the protocol as many times as we have, I'd say that both of us are pretty comfortable and confident in kind of seeing who's going to be appropriate to do what pretty early on. You just kind of learn along the way. We've also at times considered and have used family as a spotter during sessions. A lot of our veteran caregivers really are very supportive and want to be a part of everything that they're doing. So they're there to help as needed. I've had them, for instance, for somebody who has maybe a little bit of a limited motor planning and kinesthetic or proprioceptive awareness, kind of have them point out some of the things that I'm trying to verbally cue them on and they're not quite understanding. The family can be good help in that regard. For those of you that are familiar with VA's policy for telehealth, we of course, obtain the physical or ensure the physical knowing of the physical location of the veteran, and then have E911 ready as needed. And if there are any issues, and knock on wood, have not had any falls to this date, but we would follow VA protocol for reporting any of those incidents, of course, along the way.
All right, so if we take a look at some of our benefits and outcomes, these charts that we put together are from a group of 10 individuals who have completed our hybrid protocol. We've had more individuals go through the program, but we selected all the individuals that had the same data points, so they've completed all of these outcome measures. So I'm not going to go into each one specifically, but as you can look kind of across the board, we're seeing a really good improvement across all of our measures. So looking at the PDQ, we're seeing a decrease in that total raw score. Gait speed, we're seeing an increase up towards, for a lot of them, going from something that would be considering them at a falls risk or something concerning for community mobility to now be able to ambulate those community distances at a safe gait speed. 5 times sit to stand, we're seeing a good decrease in their number there. And then with mini best also seeing a nice increase kind of across the board. And then if we look at one more slide here, it also goes into our 6-minute walk test and the physical performance test, as well as the patient-specific functional scale. So the reason we included these charts was just to show the general trend of improvement across all of the measures that we do. There were a few individuals who maybe kind of maintained or had a slight decline, and we'll talk a little bit about that in the future, but there are things that we can't always take into account when an individual is participating. For example, an injury that may occur, acute pain complaints, or maybe on and off periods on the day of testing, things like that, that don't always give us the true picture of the improvements that they made. So if we look at the statistics here, I'm going to let Derek take over just to go through some of kind of our MCIDs here.
Yeah, so as Emily was saying, I think the most important point of this is to show that we are still seeing some pretty great benefit, regardless of the method of delivery. I would say that given my history on the inpatient side of things and now on the outpatient side of things, I'd say that they're pretty similar across the board. And now, of course, there are some things to consider with what we've been showing here, and kind of the achievement scores is that our N is pretty low with the data that we were using. We didn't include everyone we've delivered so far with, just kind of our first 10 actually. So that kind of impacted some of the percent of patients who achieved the minimal detectable change, or the minimal clinically important difference for each of these areas. And then in addition to that, I would say that for the most part, and with our patient considerations, we do intend that for our hybrid model, that they maybe are a little bit higher level. We do feel safe with them to be able to do these things on their own, and that they will, still achieve the maximal benefit from it. So, their baseline scores may have been pretty high to not allow for much change, in addition to some of those other things that she had mentioned. But as you can see, for the most part, we're seeing some pretty great benefit or upward trend for everyone that we've seen, with very few people either not improving or having a minimal change. And like I said, there are circumstantial pieces that are playing into that as well. But that's just kind of a rundown of what we're seeing.
And one thing I just want to pop in and mention is, we talked before about sometimes the limited space patients might have at home. So when you're looking at the gait speed and the 6-minute walk test, you may notice that those percentages of those who are meeting those MCIDs or MDCs are lower than those who met, for example, the 5 times sit to stand. So we take that into consideration as well, that could there be a role of not as much ability to complete that gait training impacting these numbers? For sure. But I think, as Derek was saying, for what we have and what we're able to do, I think these numbers are pretty great.
So, of course, as we've been developing this now, it's been, as I said, going on 2 years of us doing this. I think we've come along and have been learning a lot of things and continue to learn along the way. But as I had kind of mentioned or alluded to before, we recognize who's going to make a good candidate. And I will say that, higher level people are generally a little bit better, just because there's a little bit more freedom for them to be able to move around, maybe feel a little bit more comfortable with them walking off of the camera. Now that things are getting, our weather's getting a little bit nicer, we have asked for those that are able to move those things maybe into their outdoor space in their garage, in their garage or out into the driveway and things like that. And also, obviously, with the technological aspect of what's needed, we want to ensure that these people are up to snuff with working their technology, so that we don't run into so many issues. Of course, there's always some issues with technology, and at times we do have some troubleshooting that needs to get done, but we want to make sure that the individuals that we're serving at the time are at least somewhat technologically savvy to be able to do those things and understand what it is that we're asking them to do when we are troubleshooting. We like to have those people that are somewhat close, but maybe, wouldn't want to be doing it 4 times a week. We've had plenty of people come from, 30 to 40 minutes away and feel okay with doing that 1 time a week, but you start getting into a few more than that, they're like, that just seems like too much to ask for. We're of course continually learning ways to adapt tasks virtually, make them appropriate for the veteran as not only when they begin, but also as they improve. We're trying to grade that and meet them where they're at, while still challenging them to the needs of the protocol itself. As we had kind of said, ways to utilize the environment and determine adequate challenge level within the 2D world. It's tough because we can't follow them around their house. The camera is it's stuck to where it is when they are moving. We're not having them carry a laptop or tablet around. Of course, that would be great if we could do that, but it's just not necessarily feasible. So that does limit us with things like gait training, but we do our best to do so, given the space that they have provided. Of course, we prefer, if you can, one of the nice things about the VA is that we can loan out iPads, so that we're not limited to a desktop specific space. Oftentimes desktops are stowed away in a small office space that really wouldn't allow us to do a lot of the tasks that we want to do, getting up and down from the floor and having enough room to even do a big sit to stand. But the iPad or tablets definitely afford us that ability to do so a little bit more. And then, if we don't have somebody that's maybe technologically savvy, we hope, or we try to ensure that either a loved one or their caregiver is aware and able to help out as needed. And I would say that most have been very, very capable and willing to do so along the way.
So just taking a look at some of the future plans, things that we would love to do and kind of do as we move forward with our program. Kind of going off of what Derek was talking about with utilizing what the individual has in their environment, we would love to create to-go bags with some low-tech equipment that our participants could utilize at home, such as yoga blocks, a foam pad, floor dots, some of those things that we might use in clinic on those face-to-face sessions, and allow us to do a little bit of carryover between our virtual sessions and create a little bit more challenge at home. We would love to expand our model to other visit sites or clinical resource hub staff so we can reach more veterans with Parkinson's disease and other neurologic diagnoses. We would love to utilize videos online of the maximal daily exercises versus currently we're issuing the homework helper DVDs. And what we've run into is a lot of people don't have DVD players anymore, or they do and they don't know how to use them. So various reasons as to why that's been a little bit more difficult. We've been able to I had one patient in particular this last cohort who couldn't get his DVD to work. So we went through and recorded videos on his phone of him doing each individual MDE, which is obviously not ideal, but I think those online videos would be very helpful. And then we are also working to integrate use of motion gait lab analysis to obtain quantitative and qualitative feedback for both the patients and to do research. And I'm going to stop sharing my screen here so Laura can share hers. Oh, Laura, we can't hear you.
Talking away. Yeah. I'm gonna pause on sharing my screen for right now because we've had so many amazing questions come in as a result of your presentation. And Emily and Derek, thank you so much for giving us a clear and succinct but thorough overview of your program. So I thought what we would do, and thank you, Hillari, for answering some of these questions on chat. But I know from experience teaching that sometimes chat can be distracting. So I really would like to go through these questions for the benefit of all of our attendees and make sure that all the questions are answered. For all of you that are joining us, please note that we're going to try and answer as many questions as we have, and we have about 25 minutes, so it'll be a lot of time to answer your questions. Feel free to drop those into the chat at any time from now going forward. And let's just start from the top. Scrolling back up, one of the questions was, is it always the same therapist that does the virtual visits for a particular patient? Good question. Do you have a dedicated virtual therapist or not necessarily?
Not necessarily. We tried. As Hillari had kind of said, I think I had saw one of her responses, and my apologies. I was trying to scramble as much as I could early on in the presentation to just minimize the questions and things, but I was kind of losing track of where I was early on there. But needless to say, we do have a kind of dedicated face-to-face provider for each of the participants that we're seeing, but as Hillari had said, we have somewhere between 3 and 4 per cohort, and we do try to keep that face-to-face person the same along the way. But based on our leave, whether it be planned or unplanned, of course, we're always able and willing to make those changes as need be. So just for ease of scheduling, I think we kind of keep it the same person for the face-to-face each and every time. But of course, there is room for accommodation should needs arise as well. So we don't say that it has to be the same person week in and week out, but just for that ease of scheduling, it tends to be that way.
Okay. So
generally, we have it'll be 2 sessions with PT and 2 sessions with OT. So
that's what I was going to ask.
So depending on if the face-to-face is with PT, you might have 1 virtual and 1 face-to-face with PT, and then the other 2 are virtual with OT or vice versa. So it just depends on kind of the track that the individual gets put into and how it works out with the scheduling. And it looks like Hillary is going to share her screen to show you the tracks that I'm talking about. So each patient will have their own track. And then as you can see, track 1 has VVC with OT on Monday and Tuesday. And then on Wednesday, they have their face-to-face session with PT. Thursday is their VVC with PT, or their video visit for PT. So it just depends on the track and who they have as their in-person session.
So I will just clarify that we have, like for instance, when we have our therapists doing this, it's primarily 2 therapists. So it's primarily Emily and Derek that are running the protocol. And then we just use ancillary staff to help cover if needed. If there's planned leave or unplanned leave, then we have several other LSVT BIG certified providers. But we're cognizant that you do have to have familiarity as a therapist teaching virtually or doing a session virtually. So that's something that we make sure that we have our coverage staff is familiar with the platform that the VA uses for providing telehealth, so they can have some experience with that and they're not just jumping in blind.
Got it. Okay. So that's really helpful. And it seems like Emily and Derek, you guys work pretty closely together, and communication about, how you're going to divvy up functional component tasks and hierarchy tasks is happens because you're close together?
Yeah, like I said, we're always available via Teams
Yeah.
to kind of talk about
Yeah.
what we've either tried or what we've accomplished. The veterans that we're working with are great in kind of sharing with us. If we aren't able to look back, in real time, they're able to say, oh yeah, I tried this with Emily or what have you. So we kind of know that. But I will also say that just for ease of kind of coming up with some of those component tasks, we also use the puncture. Wow. The patient specific functional scale as our way of developing the component and hierarchy tasks. So we're both on board from the get-go of what it is that they've identified as things that they're trying to do. Now, of course, from an OT to PT's perspective, we might approach it a little bit differently, but we're focusing on the same ones, the component and the hierarchy tasks.
So, and then I'll also add too that we developed, this is mildly off topic, but hopefully not too much, but we do have a homework, we have a binder that we give to them that we've developed. I think that's really helpful, especially because they're, they can kind of carry it with them. It has all the necessary information. And then we run through kind of an orientation checklist with them. So that's part of the, initially they have 3 sessions that first week 1, which is the pre-protocol week. So it's designed so that there's 3 sessions so they can each do an evaluation with OT and PT. And then whoever has the 3rd session maybe does the videotaping, kind of goes through and selects the functional and hierarchy tasks, and then kind of goes through this checklist that we have developed. And then can, go through the exercises, kind of determine what else is needed, demonstrate what other resources are available to them. So that's really helpful, I think, at kind of just keeping them on track. We also give them a very detailed calendar. It is a lot of appointments. And I think the fact that it's, different modes can also be confusing. So we try to differentiate that. We put together a calendar that looks something like this. Hopefully you can see it. It just kind of really accentuate the fact that it's, whether they're at home or they're in person. The other thing that I'll say too is that one thing that did work well, that was a change that we made, is when we have our tracks that we showed, we offer this about 4 times per year. And we usually do 3 to 4 veterans per cohort. So they're still individually seen, but that's how many we run at a time. And I will say that it's really helpful to have the majority of their appointments at the same time. So for instance, track 1 is typically at 10, track 2 is typically at 11, and there's going to be some inherent variability with weeks 1 and 6, but we try to streamline it. I think that helps not only our staff, but obviously helps the veterans as well. Yeah.
Okay, that's really helpful. Visually for me, I can see that would be an excellent tool to keep them organized and keep you organized as well and running efficiently. Okay, one of the questions that came in was about cognitive screening. This was actually one of my questions too. Do you use a particular cognitive screen and cutoff score to determine if they're going to be a good candidate for this delivery model, or is it more just kind of observation over the course of those first 3 evaluations?
Well, so can I start?
You go ahead.
I was just gonna say, I think I would say we're kind of looking at their readiness over time. So we're trying to figure out if they're going to be a good candidate or not over like a number of visits. So this is before we've even decided. So we have kind of an ongoing candidate list that we're kind of like, ooh, this person's interested in doing it. We have a cohort coming up in 2 months. And then between PT and OT, we're kind of continually assessing, like, are they going to be, how are they with their current home exercise program? Can they use technology? We also offer Parkinson's exercise groups. So we kind of try to get them involved with that, so we can kind of see what their telehealth literacy is and if they're able to kind of participate and follow along. So I would say it's really an ongoing assessment. And then we also talk about it as a team before we decide, yep, this person should have a consult put in for this program. So I would say it's definitely over time. I don't know, Emily or Derek, if you want to add anything there.
Yeah, really, I think the other thing that I was going to add is that kind of what you were alluding to is that we're following these veterans on a lifelong care model. So we're seeing them even before we consider this protocol. But this is kind of what we want to do with everyone, because it does set them up for success in the long run. Just recognizing some of the foundational things of LSVT and moving that ball into the importance of exercise and moving big and building that awareness. We're kind of pushing those things all along the way, but we may have had anywhere from 1 to 5+ sessions with them before they even come into consideration for either our inpatient or outpatient offering. But we have a good understanding of what their capabilities are and how they're probably going to benefit early on.
That's awesome. It sounds really ideal that you know the veteran so well, even in advance. I think that's really a special thing and a wonderful thing for the clients that you serve. I think everyone in the audience who's in the private sector would say, oh, that sounds perfect. That sounds so great. All right, I'm going to pick back up where we were. Okay, you showed the outpatient grid. Thank you. That was great.
I just want to clarify something.
Yeah.
There's been a lot of chatter that I haven't read all of it, but it is kind of confusing. We run a cohort, but they're all individual sessions. So they're not in a group there at the same time. So they're simultaneously going through it together. It's more of the cohort for the staff because the patients don't really see each other. So, but it's not a group.
Now that is different for the inpatient side. They are running. I mean, they're doing the LSVT stuff individually, but they are running like alongside of each other in inpatient sessions or an inpatient
cohort
in the same
presentation,
room,
I guess. So they are seeing each other
together
a little bit more frequently and have a little bit more involvement in that regard.
Yeah. Just curious, it's kind of a side question, but after this cohort has gone through LSVT BIG, I'm imagining that some of them are continuing to plug in with wellness classes or different things that they're still seeing each other and, hey, it's great to see you. Heard you went through LSVT BIG, that kind of thing. Does that happen?
Oh yeah, especially on that inpatient side of things, like it's phenomenal the connections that those guys do make along the way. But even we push everyone to continue to participate in the wellness programs after they've completed their cohort, and they understand that they've been told time and time again that they're going to have to continue to do this for the duration for their lifetime. And yes, they do develop through many of our other offerings that we didn't get into, see each other quite frequently.
Yeah, I'm sure that develops a strong camaraderie and relationships between them as a kind of a support network. Yeah. Okay, some other questions about cognition. What about assessing for their capability to handle the technology? It's great that you give them an iPad and they're pretty user-friendly, but that said, some people, they're confusing. Is there a way that you screen for their ability to really handle the technology or their caregiver at home before you give the final seal of approval, like, yes, we're going to do this?
Yeah, so we generally, like we kind of said before, we'll see them, most of them prior to even over video. So we know that they're telehealth capable. Otherwise, that's something that when we're educating them and recommending the program to them, we ask them these questions like, do you have a laptop? Do you have an iPad? How familiar are you with our Video Connect platform? And then I've printed off sheets for them as far as step-by-step of how to get into their email, to get to the link, click on the link. So trying to make it as easy as possible for them. But like Hillari said before, we see them, most of them, for bouts of therapy prior to their engagement with LSVT BIG, and that can include some follow-up virtually.
Right, and even from a VA standpoint, it's a requirement for everyone to have run a telehealth technology screen before they are eligible to do these things. So we've kind of tested that. Now that's not foolproof. That's not to say that things don't come up along the way, but for those that I really do question, like, are they going to be able to handle any issues that might arise? I'm going to work with them one-on-one to ensure, like, yep, if this happens, you do this, so I'm there working with them with their phone, with their device to determine, all those things that may need to be done to be as successful as we can. But technology, as great as it can be, it may fail at times as well.
Yeah, yeah, definitely. I think, one of the benefits of the iPad is its portability, right? If you have someone else in the environment, like a caregiver, family member, do you ever say, hey, can you help take the iPad to the kitchen or the bedroom or
100%.
something like that?
Yes.
So we can practice those salient functional things?
Yes.
Okay, that's
think
great.
a lot of these folks too, they have a care partner or a family
Mhm.
member or someone that can help them, that might even help them, maybe they're the tech person, they help them get logged into the appointment, they help them position the iPad, they have some
Yeah.
support at home, they can be a spotter. I think that's another thing that will pull in, like if they're going to do some walking, hey, can you follow them so I can walk and yell through the iPad as you're walking?
Yeah, right.
Yes.
Yeah, that's great. Cool. Okay, question from Kurt. I'll just read it. Being from the VA frees up your models of care compared with traditional models of care permitted by state and federal law and insurance-based restrictions. Once you have sufficient data, will you present this to third parties to push for freedoms of using these models to support ongoing permission to use virtual models of care more regularly? So, are you going to share your data? Do you have any plans that way?
I think we always have a lot of things happening.
Yeah.
We sure would love to. So yeah, I think that's definitely, I appreciate that sentiment and just bringing that up, because I think we do get a little, I'm 16 years at the Minneapolis VA. So you do get a little jaded with being able to give people what they really need. And so, I think our awareness of kind of what's happening in private sector is a little bit more limited just because we're able to do it where we are. So,
Right.
yes, I think it would be great. We did, some of us from the VA put together a publication just about adapting group sessions. So not specific for Parkinson's, but just adapting group sessions for telehealth. That actually did get published last year, the year before. So I think it's just a matter of us getting together some time to be able to put forth some publications. But
yeah,
I'm going to put that on Emily's list.
Well, I was just going to say, now that Emily had alluded to getting a little bit more involved with our motion lab, I think that they have a lot more time and a lot more resources for the research specific aspect of these things. So we hope that eventually that might come to fruition. But yes,
yeah,
we tend to be, as the small team that we are, spread pretty thin,
right.
in terms of our availability and time to not only see patients, but to do some of those extracurricular as well.
Right. Okay, let's try to get through some more questions. Is billing the same when doing sessions via telehealth?
So it is for us. I don't know what maybe somebody in the private sector potentially, I know that recently maybe changed. Laura, I don't know.
Yeah. So if you're, well, maybe speak from the VA perspective and I'll speak from the private perspective.
So we can bill our telehealth sessions as long as we see the person, even if it's for, 1 minute or 2 minutes, we can bill that as a face-to-face code. So for instance, like if your telehealth session goes, kaput and you can't see the person anymore, but you call them over the phone, you do some things or whatever. Obviously it doesn't always work like that and we don't do that frequently, but that's kind of the rule. And then we just over telehealth, we bill face-to-face codes. So it would be neuro-rehab, therapeutic functional activities, whatever you would normally use for your face-to-face in-person sessions is what we bill for telehealth.
Yes. And if you're in the private sector, I am not like the best person to ask, but there are definitely some billing nuances regarding telehealth sessions and in-person sessions. And your best bet is to really educate yourself through APTA or the AOTA. They have a ton of information on every topic you can imagine related to, billing, insurance, reimbursement, HIPAA, technology, really everything. Okay, so there was just some questions about, what do you do after, and you guys have some virtual exercise programs, exercise groups. We touched on that a little bit. How many total visits is it? Is it a total of 19 if you added them all up?
I think it's 23.
23. Okay. All right.
Yeah.
Okay.
So we really, again, through experience, just found that having those couple extra sessions was great for if there was a tech issue or if people needed just a little bit more. We had it built in then, versus trying to just throw in an extra session somewhere with full schedules. I think somebody else asked about what are people's schedules or grids look like outside of this. So we did initially have 4 individuals all out of Minneapolis, 4 patients at a time. And we just felt like that was really a lot. It really cut down on our ability to be able to see other veterans during that time frame. So we dropped it to 3 at a time during each cohort. And I think that sits a little bit better with people, with Emily and Derek being able to see other veterans that aren't undergoing the protocol. And then we have it planned out. So their other clinics get closed, these clinics get opened, if people from the VA know all of that rule of thumb. So that's kind of how that works for being able to meet people's needs.
Yeah. Okay, great. I'll answer the next one. It was, will the slides and documents be available after this presentation? Yes, we have handouts, PDF handouts. I'll throw it in the chat again before we leave, but the recording will be available and the handouts will be available. You can access them in 2 different places. If you're an LSVT BIG certified clinician, you'll be able to find them in your clinician account in the on-demand webinars section. If you're not an LSVT BIG certified clinician, go to blog.lsvtglobal.com, and I'll type that in the chat here. And you'll look under webinars, and it usually takes us a couple of days to post those, and you'll be able to find a recording and handout of the webinar there too. Okay, one more question. How do you utilize PTAs or quotas?
So we actually do not. So this is probably a limitation to VA. We don't actually have a ton of PTAs or quotas at our facility. So I'm not sure how we don't utilize them for this protocol delivery.
Okay. If you're wondering in general how LSVT BIG is shared between PTs, PTAs, OTs, OTAs. PTAs, quotas can be LSVT BIG certified as well. If the protocol is being delivered, all parties need to be certified, right? Whether you're a PT, PTA team, OT, quota team, PT and OT, so that they really know the treatment that they're delivering. And somebody just popped in, we use a PTA who does some of the treatment intermittently and does telehealth also. Okay, good. We are very close to the top of the hour, and I would love to end with one last question. And I'll give you a second to think about it, but if you could share like one kind of best tip or piece of advice to other therapists who have never done anything like this hybrid model of in-person and telehealth delivery for LSVT BIG, what would you say? And it doesn't have to be elaborate, just one tip. And Hillari, do you want to start with you?
Yeah, I think it's choosing the right candidate is really kind of going to make or break how well it goes. I think Emily and Derek, I'm kind of on the administrative side, but I did used to deliver the protocol formally in this model. I think Emily and Derek would agree that the people that you know that you've had a little bit of time to kind of figure out if they're ready, and if you select them correctly, they're going to be very successful. It just makes it so much easier. Their buy-in, their support, their ability to participate, their readiness to engage, all of those things.
That makes sense. Good tip. All right, Emily, how about you?
Yeah, I think outside of what Hillari said, completely agree. I would say be creative for the virtual sessions, utilize their environment, utilize birdhouses, utilize couch cushions, utilize cups, utilize dog bowls, whatever you can utilize within their environment, obviously while keeping them safe, but to really provide that challenge that when you do it in clinic, maybe we're using more medical equipment, but it really makes all the difference in getting that challenge and keeping them engaged.
Awesome. Good. Derek.
Well, thank you both for taking both of the things that I was going to say. But yeah, creativity is definitely a key. Getting the right person, certainly. It's taken a little while, and I think we've all kind of come to realize very well, not quickly, but over time, recognizing who's going to work, who's not going to work. There have been a time or two where maybe we're cutting her close to getting people in. It's like, oh, I don't know if he's going to go that well. Like trusting our instinct with some of those things. Like we do know after having done it this way for as long as we have, we do know who's going to work and who's not going to work the greatest. And then the queuing, just keeping it simple, keeping it direct, keeping it consistent. I mean,
Yeah.
I'm queuing all the time because it's all about building that awareness. So if things aren't right, I'm saying, okay, stop, hold that right there. Look at yourself on the screen, look at yourself in the mirror, whatever it is that we have available, to see that they're not moving the way that they should, or their feet need to be spread out a little bit more, as Emily had said, and using the things that we have around the house. A lot of our older veterans aren't too keen on stepping on their pillows or their couch cushions or anything like that, but we find ways to convince them to do so, or find other alternatives. But yeah, just getting creative is the most important. And I think to add to that, really, I know for me personally, I utilize a lot of the cognitive complexities just to make those things a little bit more challenging because of our space restrictions. I make sure that I'm adding some of those things to take away from that awareness, making it a little bit more challenging for them, and having them count in various ways, having them name states as they're doing these things. Just anything that you can do to make it that much more challenging in the space that you have is important.
I just wanted to add just one thing. I know this came up in the chat, but I think on the VA side of things, we have really an increase in veterans that have been diagnosed with Parkinson's or Parkinsonism because of all of our Vietnam era veterans with Agent Orange exposure. We are working nationally on trying to develop will probably be a Teams channel for a community of practice for therapists that are treating people with Parkinson's disease. So hopefully that will come and you'll see that, and hopefully you'll join and we can keep talking about all of this. And I will throw my email address in the chat. You can feel free to email me with questions, or once we get some other things up and running, we can also add you to those.
Awesome. I'm just going to share a couple of last slides here. This is just some resources for you. If you're an LSVT BIG certified therapist, there is a webinar. It's a few years old now, but I think there's still a lot of good tips in it on logistics and guidelines of telepractice delivery of LSVT BIG. That's in your clinician account as an on-demand webinar. For sure, check out APTA, AOTA if you're not familiar with telehealth practice, because they have, like I said, a ton of information. There's just some information on the survey that should pop up after the webinar. And more than that, I just want to say thank you to the three of you. As you said, Hillari, there is just a huge need for therapists like you who have expertise in helping people with Parkinson's. We know that there's a huge population of veterans, especially, that are living with Parkinson's, and you guys are integral in helping them lead their best lives and just live life to its fullest. So I'm grateful for what you do. I'm grateful for everyone that attended. And I hope that this inspired you tonight to think about delivering a program like this in your area, if it helps to increase accessibility so that people can get access to a treatment that really helps them. So this webinar will also be presented again live on April 27th. Is that right? At 1 p.m. Eastern, 1 to 2. So if you have colleagues that couldn't join and want to join live, please share this with them. They can register for the upcoming webinar at blog.lsvtglobal.com. Look under events, or if they're LSVT BIG certified, they can find it in their LSVT clinician account. If you have any troubles at all, email us anytime at info@lsvtglobal.com. All right, well, thank you all, and we'll see you again soon.
Thank you.